delay. Just wanted to give people some time to log in here. This is the VTC Wilderness Medicine Journal Club Exercise-Associated Hyponatremia session. We're going to go through the WMS guidelines and then an article, and then I printed out a case report article. I think it'd be kind of fun to discuss as well. So we have two people presenting for us this evening, one of which is not logged in yet. So we're going to go out of order a little bit, I believe. Hopefully she logs in here soon. I just sent her an email to hopefully log in real quick. So I'm going to start recording here in just a second, and we will have Mason take it away with our article. And as a reminder, I know I put a bunch of articles up here. That was just for mostly further reading, because I read them all and I listed only the ones that I thought were interesting. So the one we're going on, I'll have Mason introduce, and then I'm going to click record, everybody. If you're not okay with recording, I guess you can log off if you want. I'm going to start recording now, though. Oh, it looks like Gabby already did. We're live. Go ahead, Mason.
All right, let me just share my screen real quick. Oh, it says it's disabled participant screen sharing.
All right, just activated. Go for it.
Okay, let me try it again. Okay, is that working for everyone?
I'm not seeing it yet. I see your video, though.
How about now?
Looks good.
Okay, cool. All right, so my name is Mason Hinke. I'm a third-year medical student at KCU, and I'm going to be chatting about exercise-associated hyponatremia, hypernatremia, and hydration status in multi-stage ultramarathons. There we go. All right, so just giving a quick overview. I think we'll go into this a little bit more in depth with the guidelines presentation, but a little bit about exercise-associated hyponatremia. This is due to either a combination of overconsumption of hypotonic fluids or inadequate ADH. Presentation, patients will often be asymptomatic, but they can come in with nausea, fatigue, headache, or confusion. And interestingly enough, symptoms don't necessarily correlate with disease severity. So when you see patients, if you're working in like a medical tent or in an ER or something like that, things on your differential can include exercise-associated collapse, which is like postural hypotension when you all of a sudden stop running for numerous hours. Heat-related illness, so your heat exhaustion or heat stroke, or just cardiovascular compromise. And this EAH can have some pretty severe consequences, including seizures, pulmonary edema, or death. So a little bit about the study that this was talking about. There have been numerous research articles that have looked at various endurance events, including marathons, triathlons, and single-stage ultramarathons. And the incidence of exercise-associated hyponatremia in those with marathons was 3 to 28%, triathlons was 23 to 38%, and single-stage ultramarathons was anywhere from 4 to 51%. But no one had ever done an article on multi-stage ultramarathons. So that's what this group of researchers set out to do. So this study was a prospective cohort study involving 152 participants. 24 were removed either due to non-compliance or not finishing the race. And this cohort was taken from 3 multi-stage 155-mile desert races in either Chile, China, or Jordan. And I put some pictures of some of them down here. This one right here is in China, and this one, I believe, is in Chile. So as you can see, it's pretty challenging terrain that they're going through. So these multi-stage ultramarathons are 4 consecutive stages of 26 miles, followed by a fifth stage of 50 miles that's completed over 1 to 2 days. So a lot of running. Very, very impressive that these people can do that. And during the race, athletes were given the same amount of water, about 1.5 liters per every 10 to 12 kilometers or so, and then had to carry their own food. So diving into the study protocol, athletes got a pre-race body weight and pack weight, and then repeat measurements occurred after stage 1, stage 3, and after the race, so stage 5. And then we also got blood sodium concentrations at that time too. And those measurements were also taken if they were removed from the race at any point. So some of the definitions, hypo and hypernatremia is essentially what you'd see in a clinic or ER setting, but they divided hyponatremia into biochemical hyponatremia, which was from 129 to 135, and then clinically significant hyponatremia, which was less than 129. And then weight measurement was used to look at overall hydration status. And so if patients were overhydrated, that meant they had a increase in body weight anywhere within the various stages. If they maintained a euhydration status, that means they lost anywhere from 0 to a 3% body weight change. That'd be a drop in body weight. And dehydrated was considered anything less a 3% decrease in body weight. So looking into our results here, I have two images here. The overall prevalence of EAH and hypernatremia. EAH actually increased with each stage, relative overall prevalence of 14%, whereas hypernatremia, it decreased with each stage, but was very prevalent, a total of 52% of the various participants. So there was a statistically significant correlation between post-race sodium and change in body weight. And that was a p-value of 0.02. And we can also see this correlation here of negative 0.21. So as you can see, as you're dropping your body weight, you get a decrease in sodium levels too. So throughout the race, a majority of the athletes were dehydrated. That was 55% of people. So as you can see here, a majority of them stayed in the dehydrated range, and a majority also maintained normonatremia status, so falling at this level. Overall, though, the incidence of dehydration was 36% higher compared to single stage ultramarathons. So that was the results for our finishers, our N of 124, I believe. But I think it's also important to take a quick look at what happened to the non-finishers, because those are going to be the people you'll likely be treating if you're working in a medical tent for something like this. So unfortunately, it's kind of a small sample size, but I think it's good to look at this too. The athletes that didn't finish in stage 3, 75% of them had exercise-associated hyponatremia. And that was a statistically significant value, a p-value of 0.001. And then 25% of them were hypernatremic. And then all these people with EAH, that was due to overhydration. So drinking a little bit too much fluids on the early stages, and then they had to bail out of the rest of the race. For stage 5, there were no statistical p-values between the sodium status for these patients, but regardless, we had a 22% with EAH, 33% were normonatremic, and 44.4% were hypernatremic. Excuse me. And some of these symptoms for the non-finishers ranged from nausea to fatigue and lightheadedness, most of which resolved within 24 hours, and we didn't see any neuro complications or cardiopulmonary compromise. So diving into the discussion behind why exercise-associated hyponatremia occurs, kind of have two factors playing a role here. We have a consumption of excess hypotonic fluids, so too much water, as well as the metabolic creation of water through cellular metabolism. But then we also have inadequate suppression of ADH. And that happens for a various number of reasons. First off, we'll have a drop in sodium levels just through losing it through sweat. And that will cause a decrease in plasma volume, leading to increased ADH secretion. Additionally, you'll have stress from running back to back to back to back marathons. So significant amount of glycogen depletion, rhabdomyolysis. That will cause an increase in IL-6, which can increase your ADH. And then you also have some non-osmotic features such as nausea, pain, things like that, leading to an increase in ADH secretion. All of this contributes to hyponatremia because if you're retaining fluid and sweating things out, you're going to become hyponatremic. So this is kind of a general idea for all forms of exercise-associated hyponatremia, but there are a few things that are unique to multi-stage ultramarathons. Mostly we see the cumulative stress just really impacts overall capacity to recovery. So we have a lot more of, I'm not sure if you guys can see this mouse, but we have a lot more of this, the stress, the rhabdomyolysis potentially leading to IL-6 and ADH. So a lot more of that pathway. Additionally, these athletes were running in very extreme environments. I mean, I think across the Saharan desert, it's very challenging to do so. And you're also carrying your own pack too. So you have to balance energy resources, so like food, water, versus burning resources from carrying a heavy pack too. Then we also have some psychosocial factors limiting into this. There's kind of a, with dehydration leads to a perceived, increased perceived exertion. If you think your mouth is dry, you think you're working a little bit harder, so you might drink water to prevent this. And then also many athletes are under the impression that, drinking your electrolytes or goos can prevent EAH, but actually studies have shown that that's not as beneficial as we think, or not likely to occur. So that's EAH. Now moving on to hypernatremia. So athletes in this group were 3 times more likely to experience hypernatremia than EAH, and they're also 3 times more likely to experience it compared to people in single stage ultramarathons too. The mechanism behind hypernatremia is a little complex. However, it all relates back to this underlying idea that there is a deficit in total body water compared to our total body sodium. So a few of the proposed factors that the researchers mentioned were, we get this increased exercise leads to a suppression of the thirst mechanism. We get exercise-induced gastroparesis, which leads to more ion absorption, and nausea leading to more absorption too. There's also abnormal food and fluid intake. This wasn't something that was tightly regulated by the researchers. So that's one confounding variable too. And then back to the just successive days and leading to impaired recovery. This alters the way our metabolism works. So lots of confounding things, but again, it falls back to this underlying mechanism of the total body water deficit. So some of the limitations that we see with this study, definitely some of the things that I thought about were sample size. We have an N of 124, which is on the smaller side compared to most studies. And then we also only have an N of 13 for symptomatic athletes. So we're not really seeing a huge picture of what is representative and necessarily what we'd be treating too. It's also hard to tell how applicable the races are compared to races in the US, or potentially like shorter duration ultra marathons or something like that, or relay races. We don't know the elevation change. We just don't, there are a lot of variables that are still out of our control. Um, Additionally, I think this study could have some improved measurement standards too. Um, they got data at stage 1, stage 3, and stage 5. So I think more regular intervals could occur, like measuring it before stage 1, at the end of stage 1 too. There are also, I think you could get more data, like kidney function, ADH levels, things like that. So a little bit more data to help figure out what is driving these abnormal sodium levels. And then also just closer intake measurements. It wasn't entirely regulated how much athletes were eating at recovery or the recovery process in general. I believe in this, going back to this figure, NSAIDs are mentioned here, and that wasn't mentioned if athletes were taking NSAIDs during the recovery phase. I know if I did 4 marathons in a day, I'd probably need some ibuprofen. So that could also alter our electrolyte status. So despite the limitations, I think this brings some interesting things to how we should approach medical care for these athletes. The overall message is definitely to use caution when administering IV fluids to collapsed runners, because it's simply hard to tell what their electrolyte status could be. It's recommended to use point of care lab testing so we can get that ISTAT sodium level and really know what is causing their symptoms. Another thing, this wasn't mentioned, but butterfly ultrasound could be an interesting way to look at fluid status too, but maybe it would be a little bit more beneficial in the severely fluid depleted patients, but another easy, cheap thing to improve with medical tent care. And overall, when resources are limited, knowing where in the race symptoms began can be beneficial in determining what the volume status and electrolyte balance is. So, at least with this research, early stages, athletes are more likely to be on the hypernatremic side, whereas later on, they're likely to be more hyponatremic. So I believe that's all I've got. If anyone has any questions or anything they'd like to add, feel free to do so.
I think that was very well done. Thanks for putting the time into that. Any questions on the study?
I just had a quick question about, you said the goose doesn't really help combat hyponatremia. I was wondering if you could speak a little bit more or go into a little bit more detail on that, because I definitely use that myself, thinking that I'm preventing myself from going into a hyponatremic state. Thanks.
Yeah, I was kind of surprised about that too. And to be honest, that was just mentioned in the article, and I didn't get a chance to read their citation about it. So I don't entirely know the answer to that one. Sorry.
I believe that comes about somewhere in the WMS guidelines. I think they'll get to that maybe somewhere between a third and actually guidelines, page 54. We'll get to it in a little bit of the WMS guidelines. So hold on to that thought. We'll get back to that. Yeah.
All right. Well, I can stop sharing if you want to.
Sure. Hey, Steph,
All
are
right.
you still there? I'll get her in a second. My program director, Steph Thoreau, was medical race support for this study. So I just seen if she could kind of say a couple words, but I think she's eating dinner. So just a quick announcement. Our other presenter, unfortunately, her mom was rushed into the hospital today. So she is unfortunately not going to be able to make it with us tonight, which is perfectly understandable. Life, unfortunately, has some hiccups. So we're going to change our order again a little bit. One of our students here who is on with us is very kindly, furiously reading the guidelines, getting ready. I want to buy him some time and go out of order. So I'm going to go over a case report kind of before the guidelines. My hope was to do it after the guidelines to kind of critique the case report, but I think it might be fun to do it before, think about it while we're going through the guidelines, and then maybe touch again on it, see what we could have done differently. So it's a very short case report, and I'm sorry if you can't hear me. It's windy. I'm on my back porch because it's beautiful. So if you have access to it, the case report was on the drive. Its title was Near Fatal Outcome from Absence of Information About EAH in a Wilderness Medicine Field Guidebook. So basically a couple, man and wife, were hiking in the Grand Canyon in June 2014. It was 41 degrees Celsius, so it was pretty hot out. It doesn't really mention the time they started their hike, but they began their hike. Their goal was to cover, I think their goal was rim to rim. So they start whether north or south, they descend, they cross, and then they ascend again on the other side. So they go to leisurely pace. They cover 13 kilometers with total elevation change of 1,200 meters in 6 hours, during which time the woman drinks 5 liters of water and some unspecified amount of food. They don't touch on snacks or salty foods or anything like that. So she begins feeling tired, develops a headache, becomes nauseous, and eventually develops some mental status changes. So you can kind of start thinking about what you think's going on here. So the husband was somewhat prepared, no medical background, but he brought a wilderness medicine field guidebook with them. So they somewhat prepared. They thought they could follow the guidebook. So he looks over the guidebook and says, oh, this sounds like heat exhaustion. It's 41 degrees Celsius. She's got a headache. She's nauseous. She's a little bit confused. So based on the guideline recommendations, he starts cooling measures where drenches her clothes in water and encourages additional fluid intake. So she's just drinking more and more free water. This leads to her becoming more disoriented. She gets actually like somnolent, worsening confusion, becomes weak, completely stops urinating. So complete anuria at this point. She then suddenly develops 3 grand mal seizures, does not specify duration or intervals between the seizures. He keeps looking over this guidebook and says, oh, it's not just heat exhaustion now, it's full-blown heat stroke. So he keeps getting her to drink this water, more water, finds a creek and kind of puts her half submerged in the water for 20 minutes. And now after the 3rd seizure, she remains postictal, completely unconscious. Doesn't say how far time-wise it's been now. But all of a sudden it's like middle of the night. So I'm assuming it's been like a full day outside. He makes the decision to leave her. So he leaves her somewhere in Grand Canyon, and it takes him 6 hours, but he gets back to the rim and he finds the National Park Search and Rescue Team. And if you don't know, Grand Canyon National Park Rescue Team is like one of the most busy, highest patient load search and rescue teams in the country. And they're so used to taking care of heat stroke and EAH, they're very good at differentiating the two. So they actually have an iStat, which is a little portable machine. Sorry, it's really windy out here. A little portable machine. You just get like a finger stick sample, and they can almost instantly, within a couple minutes, check for basically a Chem 8. So they can do basic profile for electrolytes. And they see her sodium is 124, which honestly, if I'm in the ER and I see somebody with a sodium 124, I usually don't bat an eye. It's not that low. But symptomatically, she's been chugging water 5-6 liters plus. You have to assume it's an acute drop. So they give her 3 separate 100 cc boluses of 3% hypertonic saline, just the total of 300 cc's. 1.5 hours later, her sodium is increased to 129, and she has pretty rapid improvement in her symptoms. Let me get back to the actual case again, but she is discharged within a couple days, 100% recovery, no residual symptoms whatsoever. No seizures again, no demyelination syndrome that you get people terrified about with reversing chronic hyponatremia. So basically what this study did was thoroughly discuss the case with the search and rescue team, interview the husband and wife, kind of figure out, hey, what were you thinking here? And then they found the book that the husband was reading, and nowhere in the book does it even mention exercise-associated hyponatremia. So now their recommendation is that every book should at least touch on it. It's much less common than hypernatremia, which we'll get to in the guidelines. I think Mason mentioned that as well. But it does somewhat resemble heat exhaustion or heat stroke if it gets to that point. So it's kind of understandable that the husband was convinced that this was heat exhaustion or heat stroke. So we'll get back to that. I just want you to think about this case when you hear about the guidelines. I just think it was kind of interesting that the symptoms do sound very similar. You don't have a means of measuring this lady's temperature. You're in Grand Canyon, it's June, it's 41 Celsius. It's kind of reasonable that he thought it was heat exhaustion. It's too bad that in the book it wasn't mentioned. So I've only seen one case of exercise-associated hyponatremia. I was working medical race support for a Hellgate ultramarathon. I think it was November, December. I honestly can't remember right now. It's typically supposed to be below freezing, but it was like in the mid 40s because we had a weird winter here. It's a 66-mile race, Hellgate, so they call it, it's like 66.6 miles. We had a guy who was convinced that the swelling in his hands meant his salt was high. So he just keeps chugging more and more water, thinking he needs to get his salt level down. We're about I'm at a race support station about halfway through the race, so about 30 miles in. We get a call by a runner that there's a patient 2 miles back who's laying on the ground, profuse diarrhea, starting to get confused, not moving. So we get moving, we find him pretty quick. He's stumbling around. He actually refuses to drink anything besides pure water. He's still convinced that all he needs is water. We try to give him bouillon cubes mixed with water and he refuses. But with kind of moral support, we get him to hike out and they take him to a clinic. But even in ultra marathons, these people, they don't recognize this and they're not told about this. So we'll get to this a bit more in the guidelines here, but you definitely see this if you work race support. Steph, are you online? Oh, yes, CJ. He did have very puffy hands. I'm getting a message from somebody else that was there.
I have pictures.
I'm here. CJ has some pictures he's going to show of the guy's hands.
I don't remember.
You do?
Yeah, he's looking for them. Sorry, we're eating dinner too. Yeah, so I got to do medical support for the Racing the Planet, the Atacama series, and they are very cognizant and do a really good job of making sure that people don't drink too much free water. Before the races, they weigh out everyone's nutritional calories that they have and require certain electrolyte mixes and actually limit the free water that people are able to get. I think I'm not sure if they were actually doing this study during one of the races where I was there, but I think they were kind of doing a pilot study for this study. And the thing that's really interesting is iStats are difficult to use in austere environments because a lot of times they're temperature sensitive and require careful handling. So that was one of the kind of limitations they were looking at for like how accurate are these iStats going to be. And it's interesting in the case studies that have had like ice or like a lot of like search and rescue and people out doing medical support, and Justin, even for like Hell's Gate and stuff, you guys didn't have an iStat to be able to actually figure out what someone's sodium is. So then at that point it's kind of a clinical diagnosis, which is actually cool because the treatment is also more clinically based than it is based on what number their sodium gets to. You just want to give them sodium until they get back to a normal mental status and their symptoms are sort of resolved. So
I just Googled it real quick, and iStat's operating temperature range is 16 to 30 Celsius. I'm not the best at converting in my head real quick, but not too cold, not too hot.
Exactly. And I think the cartridges are also pretty specific about the handling. So if the cartridges freeze or if the cartridges are outside of those kind of temperature specs, then they also won't work. Not to mention the fact they're fairly expensive, so kind of out of reach. You probably get a butterfly ultrasound for cheaper than you can get an iStat machine in those situations. But I think a lot of races are going toward trying to educate runners about this problem and doing weights and things like that to try to look at fluid gains. Kind of looking back at that the Atacama article, you could see the people who had the biggest increase in their weights tended to be the people that also had the highest chance of having exercise-induced hyponatremia.
Yeah. Drew, how you feeling? All right, Drew here was very nice to step up and work us through the guidelines, and let me know if you have any questions about it, Drew, and I can kind of jump in too. But
I'm loving this because the things we've been talking about in the last few, especially the goo packets, I found exactly what you were talking about.
All right, whenever you're ready, you can share screen, or I can pull up the article, whatever you want to do.
I believe I can share screen here. If you can see what I see. Working? Now it's working.
Looks good.
Sorry, I got the multiple monitors rocking here. Okay, so we had the 2019 update for the exercise-associated hyponatremia, and what we've done is, what's this chapter? Emergency medicine, uniform service, university. It's not like they see any guys who were of the exercise oriented out in the heat for a we will determine how long when you get done with the job kind of deal. So going down, scope of the problem, and as we were talking earlier, I mean, the majority of it's unknown how many people have this, and it's a very wide, what was it, highest 30 to 51, and how many of them are asymptomatic and we just don't know about it. The methods, which were a lot of studies, expert panel came back 2018 from articles from 2014 to 2019. But let's get down to the definitions. Down to when they're talking about pathogenesis, we've already covered this. You're just talking about this page 54, 53. But the major malfunction here was overhydration with hypotonic fluids, as we were talking about. Helping these people understand not to completely drown with hypotonic water or just pure water, as your poofy chap was talking about, that they are causing their problem by hydrating. Everything's good in the right quantities, and so is water. So overhydration with hypotonic fluids was our major malfunction. Sodium sweat loss was controversial, highly variable between people. Risk factors, and further down in here, talk about the pre-race, post-race, and I'm not sure how applicable it could be on in the middle of things. I don't think anybody's going to comply with that on what is their fluid status based on body weight, because that seems like the quickest. And we're talking about iStats, that you point of care with an iStat is optimistic. And I can actually remember back in a community college back home, ordered some iStats for I didn't ask why, but they got them delivered in the middle of December while everybody was gone, and they all froze. Like $250,000 worth of iStat equipment. This policy of sustained overhydration during the exercise should be avoided. Education, checking on their fluid balance. If we can do that, we can prevent them from causing their own hyponatremia. Educating staff on this, as you said, the park rangers of the desert are very, very well versed. And as a measly paramedic, we maybe covered this in a paragraph in a book many, many years ago, and so we don't know anything about it. They do say we can discuss this, but again, it's situational. It's if the staff who are involved are well versed on this, it'd be much more beneficial than everybody. Avoidance of overhydration is grade 1A. Again, if they're going to be involved in strenuous activities, if we can prevent people from overhydrating, and believe their word is using drinking if you're thirsty, not just drinking water for the sake of drinking water. If I haven't been drinking water, obviously I'm dehydrated. No, if you're thirsty, drink your water. Yeah, drink according to thirst. Body weight by loss per hour, as we discussed. Here we go. Supplemental sodium and oral intake. Sodium supplementation with exercise during exercise with overhydration has not been shown to prevent development of hyponatremia during physical activity lasting less than 18 hours. May attenuate the decline of concentration when drinking beyond thirst. However, you cannot, should not eat enough goo packets to overcompensate constant chugging of hypotonic fluids. I do not have a goo packet on hand, but if we could crunch the numbers, we could figure out how many goo packets you would have to eat per liter of water to make the balance equal. It does not say we can't. It does say that they're not really going to help. Pre-hospital treatment assessment. They're talking about the iStats in here. Point of care diagnostic equipment is problematic and expensive. I do not know how much any of the individual iStat equipment is, but I am aware it's not cheap. And it just said the optimally 30 degrees Celsius and how many of these ultra marathons are run in these conditions and how many are run at obnoxiously hot for the sake of being an ultra marathon and obnoxiously hot. Not that I have any room on ultra marathons. I ride a chair right now. Point of care should be done, but again, limitations of the equipment. And if we can assess the patient's hydration status, if they are able to tell us how much of what kind of fluid they have ingested, what kind of quality food they've ingested, and they're presenting signs and symptoms, which are further down on this, that we can use. Team considered always differential diagnosis. This is where we're getting to where our lovely chap in the desert, he had his old book, but this is the splitting hairs of between, is it heat or is it lack of salt? And there's a lot of overlap between these two. Seizures, both dizziness, headache, weakness, they're all very close. The exertional heat stroke, which we've covered before, was, while we may not have a measure, I mean, your heat stroke are hot, warm, dry, not your I can be diaphoretic because I have the fluid to spare, but the heat strokes are your hot, warm, and dry. This was during the ultra-mental status swing on the right, but also it can resemble close to your severe hyponatremia secondary to drinking 5+ liters of hypotonic fluids while you're out and about. And again, previously, I mean, I've had the mantra of, what was it? The sodium's low, the brain will blow, something like that. That was horribly rhymed, but works. IV boluses of 100 mils of hypertonic saline, 3 doses, 10 minutes, and with under controlled circumstances of we're actually throwing measured doses at established intervals. There were, I'm not going to say no, but none that I read over that screamed adverse circumstances if we're giving hypertonic saline in a controlled, predetermined, regimented, guideline-driven manner. Left side over here, we're talking about alternate mental status, weakness, dizziness, headache, nausea, vomiting, muscle cramps. Not quite your guy on the side of the road, because I believe he was in the alternate mental status, but heat exhaustion versus dehydration. Again, if they are able to answer how much fluid or what they have consumed relative to time and exertion, this can help us split the difference between the two. Let's see. Chat. Yes. Sorry, the chat button was blinking. Let's talk about page 54 on the supplementation of oral intake. All right. The chat has the math for 55 milligrams sodium per goo versus 9 grams in a liter of normal saline. Let's see. Down, discussing mild hyponatremia. oral fluid restriction, how much you're drinking. I guess it's that point, it's oral hydration hygiene. It's consciousness. If they are mildly, we can restrict them. They'll take care of the rest. This is where we're talking about the oral, trying to use hypertonic solutions oral. While this is possible, as they are not in the altered mental status wing, if they're in the mild hyponatremia, quote, unfortunately, oral hypertonic fluids may be unpalatable. Yeah. Higher salt may increase serum sodium levels if tolerated. Given the risk of hyponatremia worsening after the nasal presentation, again, we're talking to close monitoring of at least 60 minutes if we even suspect one of these things, because they may momentarily correct their guts retaining a bunch of hypotonic fluid that they've been chugging for who knows how long. As soon as they start moving again, they redistribute their hypotonic reserve, as we'll call it, and they're hyponatremic again. Intravenous solutions, cellular dehydration, isotonic fluids, IV hypotonic fluids are not going to help us. I mean, that's, while a hypotonic fluid is technically, no, it's just not going to help at all. Then we get into severe hyponatremia with our altered mental status wing. Again, and this is where our lady was talking about between the seizures. Is she seizing because she's having an exertional heat stroke? Or is she seizing because she's severely hyponatremic? Prompt recognition, immediate treatment of 100 mils hypertonic saline IV. One fatality. Again, we're measuring hyperthermia, and if we're going to talk about carrying an I-stat into these situations, we can also manage a thermometer. But it was with active cooling and things are not improving, we can almost safely assume that they are hyponatremic, and when they prescribed 100 mil hypertonic saline, 3 doses every 10 minutes. Recommendation, IV bolus, 100 mils hypertonic saline should be administered immediately if signs and symptoms of encephalopathy and hyponatremia is strongly suspected. Pre-hospital transport, this is again terrifying that I think about my paramedic education, and we maybe covered a few of these things once or twice. Paramedics love bags of fluid, but a lock, and all we have on the truck is isotonic, so they should go. Notification and awareness of the subject is key to keep us from making it worse. Alert to the danger, report. Against. All right. Acute in-hospital treatment. Oral and hypotonic oral, hypotonic, or isotonic should be avoided. It's not going to correct it. Sodium estimation should be attained because we need to know where we sit. Cerebral edema, non-cardiac pulmonary edema. Again, you're gentlemen with the poofy hands. And again, a prescribed, not just willy-nilly, we were all thrown at correcting hyponatremia will demyelinated pons. I imagine so, with enough of anything, but with a predetermined set dose, we can do this safely and correct, even with our lady who had multiple seizures and fixed, and she's fine with a controlled predetermined dose. Major malfunction was not so much a lack of salt intake, but it's difficult and distasteful to ingest enough salt to be able to correct ingestion of hypotonic solutions, pure water. And if people can be aware, especially the caregivers, and educated about it, and we can optimistically have point of care assessment, we can do a lot more about this. And preventing hyponatremia in the first place with a consciousness of hypotonic solutions. And again, the weighing in to find out, do you really have a water deficit? Drinking if you're thirsty, and consciousness of the situation, and a system of care for after we established it, both in relaying the information to the receiving facility, and if we all go by the same guidelines, when we're administering the hypertonic saline, hopefully one day we'll get to not worry so much about osmotic demyelination. And that's all the guidelines have.
Christian, can you put back up the algorithm slide before you go off, or can somebody else put that back up, please?
Sure. Tell me about it. Sorry, doing sketchy. What are we looking for?
So the main treatment algorithm page where they show the algorithm going down through the mild and severe treatment of hyponatremia.
Let me zoom this out.
That's good. You can actually zoom back in a little bit so people can read a little bit easier, but that actually works pretty well. Sorry, this is Ben Chopsky. I'm an internist in Richmond, Virginia, and I work with Steph and some of the other folks here helping along the way. A couple of comments. Christian did a good job of summarizing a fair bit of stuff pretty quick. This is one of those classic scenarios where you have to always watch a little bit with a little bit, ironically, a little bit of salt in your guidelines. Take things with a little bit of salt, because when you look at the quality of evidence behind many of the recommendations that the WMS group has made over the years, with the exception of the 3% saline for confirmed severe hyponatremia, almost all of these are 1C and 2C recommendations. So the evidence behind a lot of this stuff is relatively weak, and there are a lot of these big areas that you're really just looking at expert consensus opinion. But in this case, that's all we've got. The best 1A recommendation you actually have in the entire guideline is actually for the on the severe EAH branch there, down in that treatment for, yes, we definitely know from treatment of patients in the ED and in the hospital, those 100 ml boluses of hypertonic saline are reasonably safe, and definitely given one or two of those in the field is very low risk relative to benefit if you truly think that you have severe hyponatremia, because you only have to get down to a sodium of around 125 before your seizure risk goes up pretty significantly. And that's not going to get better until you correct the underlying sodium. So that's actually the strongest recommendation that they give. But in their consensus, they bring up some really good things. So on that milder side of the algorithm, on the other hand, where people come in with suspected mild EAH, even if you can't confirm the diagnosis with your labs, then one of the things they of course mention is fluid restrict until diuresis. Christian mentioned kind of watching them for an hour, but the real details when you've read these guidelines and some of the articles that they're based on, it's really, you sit them down, you fluid restrict them. So you might hand them a small cup of something, but you're not giving them bottles of water to drink. Give them their salty snacks, but their end point is really when they start to pee. Because going back to that whole pathophysiology, a lot of what's driving this, it's the combination, right, of elevated fluid intake and non-osmotic ADH secretion. Well, what is ADH? Antidiuretic hormone. The body is not going to self-correct that sodium level until the ADH drops. So what you're trying to do is get them rest, taking the stressors out till the body realizes, oh, we aren't hypovolemic anymore. We're not stressed anymore. Let's drop that ADH. And now they should start autodiuresing, and then their body will correct its own sodium. So sit them down, give them the salt, but you really shouldn't let them go until they can start peeing and they have somebody to go with them and watch them, so that if they do for some reason decompensate after they leave, there's somebody with them and they're not, having a seizure in their car driving on the way home. So the oral hypertonic solution, there's been some really good discussion here in the group about like the goo pack. Unfortunately, your goo packs and your sports drinks are relatively worthless for this. If you look at your average Powerade, for a prior presentation I did for the student conference, the Southeast Student Wilderness Medicine Conference about 2 years ago, I talked on EAH, and I actually looked up the Powerades. It's 20 to 30 milliequivalents per liter of salt in them. They're more sugar than salt. The salt is really there to make you feel like you're getting electrolytes more than it actually helps you, because your normal saline has 154 milliequivalents, and that's still that's just to get to isotonic. Hypertonic saline 3% is 500 milliequivalents per liter. So that 20 milliequivalents that's in your Powerade, or whatever the 55 milligrams, whatever that is in milliequivalents in your goo, is nothing. If it doesn't taste like you're sucking on a salt lick, there's not enough salt in it. It needs to be, it needs to be ramen salty to matter. And they actually mentioned that in the guidelines here about the amount of sodium that's in a ramen packet. A ramen packet in, a half a cup of water, that's salty enough to actually try to raise their sodium if they don't vomit it up in the process. So if they can keep it down. And then other than that, the only other new thing that was in these guidelines was this nice table here, just trying to remind you of what's in your differential and trying to get you to focus on things like your physical exam of, okay, are they hyperthermic? Okay, think more heat stroke first. Are they orthostatic? Okay, then they're probably more volume depleted than they are volume up in hyponatremia. Okay, let them drink to thirst. So that's just a couple of comments from having kind of worked through these guidelines a couple of times of the details. So thanks for giving me a moment.
All right, I had to run downstairs. It's so windy, my papers blew away like 5 times. I couldn't handle it anymore. It's kind of interesting. Jory was mentioning this. Excuse me. I gotta let somebody into the mess from the waiting room. They really in the guidelines don't talk too much about hyponatremia, and I think part of it is when I read through all the letters to the editor, the authors I think had different opinions on whether to include hyponatremia in the guidelines. I think the symptoms are similar, the treatments are obviously different, and they didn't want to confuse the two. Hopefully they said either add them to this guidelines or make a separate one, but Jory was very right. The symptoms are kind of overlapping, and they very much overlap with heat exhaustion as well. But the guidelines also don't touch much on ADH, like Ben was talking about here. There's an article that I put in the Google Drive, well, 2 actually. One was called Hyponatremia in Marathon Runners Due to Inappropriate Arginine Vasopressin Secretion. And the other one is Exercise-Associated Collapse is Hyponatremia in Our Head. Basically ADH acting on what part of the body's receptors. So one of those 2 articles was talking about how, from their point of view, the overconsumption of free water during race might actually have less of an effect than is thought. And it might be more of a factor of ADH secretion inappropriately due to like the trauma on your body of ultramarathon running. And everybody's response might be different based on their personal like physiology. So like Ben was saying, the overall sample size of these studies is very low. Wilderness medicine studies in general have low sample sizes, but one of the studies had an encashment period of like 20 years of dozens of races, and there were like 16 people with EAH during this entire time. It's hard to study this topic because there's very few patients that actually have it. And so your sample size is minuscule. It's kind of hard to figure out pathophysiology and trends when your sample size is small. But On a little bit of a tangent, I think this was kind of interesting. Does anybody know when EAH was first identified and like published? It's not been that long.
1990s.
Close. It was 1981. And I didn't know why until I looked, but you're very close. So there was a ultra marathon race in South Africa in 1981. Apparently before 81, sorry to anybody who was born then, I wasn't born yet, but before 1981, they told people like not to drink during exercise. So after that, and I'm curious about when Powerade and Gatorade came out. I kind of wonder when that came out, but in 1981 is when they started telling all athletes in these events, drink between 400 and 500 cc's per hour. And then people started saying like, oh, we got to drink a ton. There's a specified limit. And then Gatorade and Powerade came out saying like, hey, it has to be tons of fluids. And then in the 90s and early 2000s, you start seeing tons of water containers at every single training event and sports event. 1965? All right, I was wrong. It was a little bit earlier, but and then you get people giving specified amounts rather than drinking to thirst, what it kind of used to be. So it's kind of interesting that it's somewhat of a new phenomena based on potentially advertisements, incorrect recommendations. So I just thought that was kind of a real random tidbit, but
it's actually newer than that. You're on the right track. If you actually look at that original case report, the case was in 1981, and I only know this because I'm looking back at, I have the article, but it wasn't published. The guy didn't write up the case report until 1985. So it was the mid 80s that this was like first, and it was first reported in South Africa, I think in like a sports medicine journal, Medicine and Science in Sports and Exercise. So in the pre-internet day, God knows who ever actually saw that article when it first came out as a case report from South Africa in some journal that probably none of us ever would have read.
yeah. So like medicine is very cyclical and swings back and forth, but it would be nice to see how this develops over the next couple of years to see if they get more recommendations rather than drink to thirst. But I think it makes sense to myself. If I'm mountain biking or running, granted, I don't do much cardio because I hate it, but I'm not just going to chug because my bottle's full and I'm wondering why my bottle's full. If I'm thirsty, I drink. So it makes sense to me. So back to that case report, based on the guidelines in the article we meant, let's say, what would we have wanted to put in that guy's wilderness field guidebook that he had with him? What would you want put in there comparing heat exhaustion and EAH so this guy could have figured out how to treat his wife appropriately? Any thoughts from students, residents, anybody like that? Sorry, Jory, if you're talking, I can't hear you. Close, you're close. Maybe I can unmute you.
I did it. So I guess it's obvious that he probably should have also given her some snacks, even if he thought she was super, heat exhausted. Then, hey, here's at least some snacks, recover some calories, something to that effect. Hey, here's at least something to eat at minimum.
Yeah, it doesn't specify at all what she ate. And Jason, I agree, seizures are potentially indicative of water, but yet with heat stroke, you can have seizures too. So based on his book, it probably said seizures or heat stroke. So yeah, like somewhere in the guidelines, it was saying about what? Yeah, somewhere in the guidelines, it was talking about how don't just take salt while on an.
Now you're muted.
I am? I'm not muted. So it's saying that like can everybody hear me?
Now you're muted.
You're not muted. I can hear you.
Jury, I don't know what you're doing.
Murder, death, kill. Yep.
I can hear you, Justin. You're definitely not muted.
You're being trolled, man.
Sorry. I'm sleep deprived, and we'll go with that. Anyway, so the guidelines were saying, like, don't just take salt to like prevent it, but I think taking salty snacks, trail mix, peanuts or whatever while you're hiking, at least personally backpacking, will at least help balance out preventing hyponatremia, as long as you're drinking to thirst, balancing those two. But ultra marathons, multi-stage marathons, and things like that are a little bit different. So one of the articles is actually saying maybe we should limit the free water availability at each rest stage. So every time there's water and people handing out cups, maybe they need to reduce that. That's kind of interesting to see. So yeah, I think I would add EAH to that little handbook, even if it's a paragraph or two, just showing that it exists. He could have seen the two and been like, oh, maybe I should stop having her chug water. So it's kind of interesting. Any last minute thoughts, any additions anybody would have?
Justin, I have a comment, if it's okay.
Please.
I've presented this topic twice for emergency medicine residents, once like 5 years ago, and then once just a few weeks ago, actually. And in an effort to make it interactive, I made a potion, a hypertonic solution, with 4 bouillon cubes per, it was half cup water. And that was based on the original, guidelines. And then the updated ones also mentioned 3 ramen seasoning packets. And so I did that. And first of all, it's hard to dissolve that stuff. So I ended up heating the water and stirring in the electrolyte, and hoping it didn't settle out. And I brought it to emergency medicine conference, and I of course got residents to volunteer to drink it. And these were residents that, sure, they were sleep deprived like yourself, and but they were not exerting themselves in the same fashion. And some of them could drink it, some of them had to spit it up and vomit, which made for quite an entertaining lecture. But my 2 points is, one is that it's hard to make, and you'd have to be sort of prepared to do that. And 2, if you're already nauseous, I don't think you're going to be able to tolerate it very well. It's possible that if you sit for a while and chill out and maybe you urinate, a little bit, you might be able to slug it down. So it's not as ideal solution as you might think.
Yeah, I've only seen it mixed once, and I think CJ, I know, I think I heard Lonnie and Steph laugh in the background. So CJ, I think you're there. When we were mixing bouillon cube and water in like just a plastic water bottle, I think we only put 1 bouillon cube in it, and it did not dissolve. Granted, we were in ambient temperatures somewhere in the 40s. I don't think we poured out enough water to get the emotion to help agitate the water. It was hard to dissolve.
I had to crush it too, as well as heat the water.
Yeah.
And again, even a well hydrated resident, half of them wanted to puke. So
yeah, so it's hard to take a patient who's already feeling horrid.
Exactly.
And have them take something really salty. So it was,
I did not myself volunteer to drink this stuff.
I had a quick question regarding the drink to thirst guidelines as well, or that kind of recommendation. My background was actually in wildland fire, and I think for a lot of our crews and a lot of people that work in it's a different environment from like more recreation or these really high intensity races. But our recommendations have always been, our guidelines have been, if you're thirsty, you're already behind the hydration curve. And I think the focus has always been on hydration, and not nearly as much on hyponatremia. And I'm curious if you guys think there needs to be a balance between these guidelines for preventing hyponatremia at the risk of it increasing dehydration, or if you think that maybe like the old teaching on being behind the hydration curve if you're thirsty ever is maybe a little bit bogus.
I think it probably is, but I'm not an expert in this topic. I've just read a like a nerd a bunch of different articles and gone through residency and stuff. But based on everything they say here, you should not gain weight during exercise. So if you're running, you're in an ultra marathon, no matter how long your race is, you shouldn't finish a race and have gained weight.
Yeah.
So if you're drinking enough that you've put on water weight, it's probably not good. And that's probably them chugging because they're worried about becoming dehydrated. So you're right, there's a balance, and I'm not entirely convinced we have a clear set true guideline, and it's probably very individual specific based on everybody's individual experience and tolerance and personal physiology. So I don't know how we'll figure that out, but there's probably a lot more work to do.
Justin, a lot of the articles suggested that a small decrement in your body weight, 1 to 2, 3% really had no performance impairment.
I think one of those articles said all the winners in like the top 10% did have a reduction in body weight.
Right.
So, and I see a couple people talking about pickle juice. Just as a personal anecdote, when I ran track in high school, one of our star athletes, the 1 mile, so I think it was a 1600 meter back then, but he would start his day during school. He would drink 4 Red Bulls, was his high school prep, and then before and after the race, he would drink pickle juice. So I guess it's been around for a little bit longer. He was able to run a mile though in 4:36 back in like junior year of high school. So worked for him because he had darn good mile time. But yeah, it's definitely been around for quite a while. I don't know too much about the exact salt contents of pickle juice. I bet it's pretty high.
Someone should probably reach out to Knowles. I remember doing my Knowles course, and they had us like competing who could chug an entire, Nalgene of water the quickest. They were like, "We're not leaving until y'all chug an entire Nalgene of water." And I'm just like, thinking back to it now, maybe that was probably not the smartest thing.
Yeah, the kind of notion of prehydration is definitely around in the outdoor industry. Prehydrate, post-hydrate, drink, stay on top of it all day. Lots of free water.
So I had one last little anecdote of my own, and I didn't put this pieces together until we read these articles back in like November prepping for Hellgate. In college, my roommate was like 6'7". He was enormous. And he was like maybe 250 pounds. I don't know who dared him, but when we were at our cafeteria dining hall one night, he filled his entire tray with full glasses of water, drank every single one. And for like a day, he was throwing up, tired, weak, headaches. I'm not sure what his sodium content was, but his serum sodium was probably pretty low. Looking back, he was probably not doing very well. So it's not
There's been a couple of cases of people who have died from radio contests. One lady, one time they had people trying to drink a gallon of water, but another time was a milk contest where they had a contest where somebody was trying to drink a gallon of milk and died from it. It was likely similar. I mean, when you think about it, milk is still mostly free water. It's got some protein and other stuff in it, but you run into the same problem.
Yeah, these challenges like the Tide Pod stuff has been around for longer than we thought. Started with the cinnamon challenge. Anyway, any other anecdotes, questions, additions? All right, I think we had a fun discussion. It branched off and fun topic. So next month, I believe, is water disinfection. Let me pull up the exact date so we're trying to like advertise as we go. Anybody have it up in front of them? Hold on just a second. May 26th, 7 p.m. We're doing water disinfection. So not the most stimulating topic, but very important. We've all, I'm sure, had personal experiences of when we're not careful. So we'll talk about what to do and go through cases and things like that. So thank you very much for everybody for joining. Thank you, Drew, for doing a crash course on the guidelines and then presenting them for us. So, all right, thanks everybody. I'll see you next month.